Thomas.
Good morning. Thank you for the invitation, and thank you for the opportunity to share our data with you. I am from Vienna, and we are working with capsule endoscopy since 2003. So we have experience now over 18 years. And I will bring some data of our clinic, and I will give you an overview what's going on with capsule endoscopy in IVD. So these are my disclosures. So why do we need capsule endoscopy in Crohn's disease? The capsule endoscopy is the most sensitive small bowel examination. There are a lot of data that the capsule endoscopy is superior to MRI and CT. We have a direct visualization of the entire small bowel. And what we are searching for are those early mucosal injuries. You know that we have a bad prognosis for those patients with jejunal lesions. Those are those patients we have to have a good therapy to start with immunosuppression very, very early. And I will show you a short video of a CapsuleCam study in a Crohn's patient. And I know all of you are experts and you can see those small lesions, but I will give you here some pictures of those small lesions. You can see here very, very early mucosal injury with here a bigger one. Please look at this only small inflammation in this area. The rest of the small bowel is totally free without any inflammation signs. Here we have a bigger one with a little bit inflammation around. Here a smaller one. So those are lesions we can't find with MRI, with CT, because they are only in the mucosa and they can't catch it. And I want to show you a paper from the DDW 2018 from Sorrentino and Nguyen, and they compared ileocolonoscopy, MR enteroclism, CT enteroclism, fecal lactoferrin and CRP with capsule endoscopy. And they divided the patients in two groups. One group without surgery, and in this group, the imaging failed in 53%. It's only a small number of patients, but we can see the same in our patients, and I will show you the data at the end of the presentation. CRP and fecal lactoferrin were normal in 35%. So we miss a lot, and we know it from the clinical day work. We have patients without a pathological blood sample. We have an imaging, but without any pathologies, but the patients have symptoms. It's a little bit stronger in the post-surgeon group, because here the imaging failed in 75%, and CRP and fecal lactoferrin were normal in 42%. This leads to a change in patient management in both groups with a high number and a good improvement. So the conclusion of this paper is that there are significant lesions we only can find with capsule endoscopy. Other questions we have we advantages to other modalities? Yes, we have. I showed you on this paper, and we know it from a lot of studies that we are superior with the capsule endoscopy, even in the early stages with the small lesions. If we have a severe inflammation with a thickened wall or fistulas, that's the domain of CT and MRI. Changing management and therapy, yes, we've seen it at all. And I think every examination we perform should have the aim to change the therapy, even if it's a step up or a step down therapy afterwards. Fear about retention? No, but respect. We need respect. And we have brand new data, and I'm very happy about this because we have now in this, show you the paper afterwards, we have now a retention rate in suspected Crohn's disease of 2% and in known Crohn's disease of 5%. In the past, in the older studies, we had for the known Crohn's disease retention rate up to 13%, and that was a big number for those colleagues who don't like the capsule endoscopy or are not so that they say we have this examination is value for this. And this is a meta-analysis of a big number of studies from last year. It's a really good work. Please keep this in mind. 2% for suspected, 5% for established Crohn's disease. Are there any issues, any modalities to say, to do an examination so we can avoid capsule retention? And there is one. It's the Pilgrim patency. This patency capsule is an dissolvable capsule in the shape of the Pilgrim Crowns. It's here to rule out stenosis, and the capsule should be excreted within 30 hours. If she's excreted, you can perform capsule endoscopy and we will say there's no stenosis. But we have a small problem because this capsule starts after 30 hours to dissolve. We have here on both sides a timer plug, so fluid can get inside and after 30 hours they start to dissolve. But then the capsule shrinkles down. You can look here with a patency scanner if the capsule is inside because of this FRI tag. You also can do an X-ray. And if this shrinkles down, we can have a problem. And I will show you this work from 2016. It's a multi-center study of symptomatic retention of patency capsules over a year from over 10 years, included as 629 cases. And it's a small number, but 6.3% have abdominal pain, vomiting, obstructive symptoms, up to a subileus symptomatic. So 87% are solved spontaneously without any intervention or without any therapy within 72 hours, but 3 days with symptoms. And overall, we have a really small number, but 0.8% need surgery. You know, if we have a capsule retention with the capsule, the patients don't have any symptoms. The capsule will swim in the dilated area before the stenosis. And I've never seen a symptomatic patient with a capsule, but here now with the Pilgrim patency, we find symptomatic retentions. And that's one of the reasons we don't use the patency capsule. And the last question we have to think of is, how can we solve a retention? And I will give you here a short video. So we have to know, do we have an enteroscopist who can solve this problem? Do we have good surgeons? Have we a center nearby who can solve this problem? This is a young lady after a segment resection in the jejunum with a jejuneal anastomosis, and with a non-symptomatic anastomosis stenosis, and it's too narrow, we can't pass with the enteroscope. So I have done a balloon dilation in the next step. And after the balloon dilation, we can go through very easily. And here nearby, we have the capsule in the dilated part of the iunum, and we can grab it with a basket and bring it out. We have a lot of guidelines of capsule endoscopy, and I'm want to show you some of them. We have here the American guidelines. They say if we have a suspected Crohn's disease after negative ileonoscopy, just do a capsule endoscopy. I'm not so happy with this, but they say that they recommend a patency capsule or small bowel follow through CT or MRE before capsule endoscopy in patients with no small bowel CT involvement. We don't do that in my unit. I will show you the data at the end. And they recommend capsule endoscopy in patients with known Crohn's disease and unexplained symptoms. So it's a clear statement pro capsule endoscopy. And I will show you the old guidelines from 2016 of the ECHO. And the ECHO in those years say capsule endoscopy only after ileocolonoscopy and radiological examinations. And that's why I've not been very happy over a long period, but in 2018, we have new guidelines, and now we have convinced the skeptics, and now they also say we can do capsule endoscopy or cross-sectional imaging. And all newly diagnosed Crohn's disease patients should undergo small bowel assessment. For those after surgery, it's clear a patient with an ileocolonic resection needs ileocolonoscopy as standard, and for patients with a partial resection, small bowel capsule endoscopy is once more here at the first part. And the last guideline, the ESGE guideline, and here I'm very happy because the ESGE says we are not recommend routine small bowel imaging and the use of Pilgrim patency prior to capsule endoscopy. So those are the guidelines. Every nation have their own guidelines, but I think those three guidelines are very helpful to know what to do with Crohn's patients. And then I will show you the available systems. I will highlight the systems I'm working with. We have three different systems in my unit. We are working with the Capsule Plus. It's a 360-degree panoramic view. We need no data recorder or sensor belt because we have storing inside. We have a 1 gigabyte data chip inside where all the data are stored, which means we need the capsule back. We have 4 cameras. We have an adaptive frame rate up to 20 frames per second, a size of 11 by 31 millimeter, 16 LEDs to illuminate the lumen, and we have a fantastic recording time of 20 hours. And a very short download time of 30 minutes. The second system we are working with is the Pilgrim Crowns and also with the Pilgrim SB3. Pilgrim Crowns has a view of 172 degrees. We need data recorder and sensor belt. We have two cameras at the ends of the capsule. We have also an adaptive frame rate up to 35 pictures per second. The size a little bit bigger than the capsule cam, 8 LEDs, and the recording time of only 10 hours, and a download time of more than 90 minutes. We can get with the Pilgrim Crowns a totally passage from the mouth to the anus. It's built up with a special protocol to get also data from the colon. But we have a little backdraw because of those good features and those enormous data we require. We have only 10 hours recording time, and we have a little bit not so good image quality. We have here the quality from the Pilcam SB2, so the older generation. But quite good product, really good results. And the last we are working with is the Marocam MC2000 with a view of 170 degrees. Also, we need data recorder, sensor belt. We have two cameras. An adaptive frame rate is not included. We have a constant frame rate of 6 frames per second. It's equal to the capsule cam. We have six LEDs and a recording time of 12 hours. That's what we are working with, but we have also another number of good capsule endoscopy systems like the Omon or the Olympus capsule. Download time of 35 minutes. So, and I want to show you our data. We've done now nearby 3,800 examinations since 2003, and I will highlight this here. The year 2020, we've done 68% with capsule cam, and I will show you why we have done this. We have a 360-degree field of view. It's the largest field of view, and we can find more pathologies. And why do I think this? And I will show you some studies of the visibility of papilla fateri, some older studies between 10 and 18%. The papilla fateri is the only landmark we can find in non-surgical patients. Then with the Pilgrim colon in 60%, and with the first capsule vision study 71%. I will show you a short video of a papilla, she's spitting spile. And in our data, now in more than 1,300 examination, we can see the papilla in 81%. So that's why I think we can see the papilla in every patient, here in 81%. So we will also see more pathologies. And now I will come to another good features. It's easy to handle, just take it out from the package. The patient can swallow it and you can start. We have no interference with other devices because all the data are stored on board, but we need the capsule back. It's the best comfort for the patient because you don't need sensor belt or data recorder. And it's also a kind of patient safety because we know that the capsule is 200% excreted. And I will show you our data we have presented at the UEG Week 2019. We are included nearby 2,000 patients, big number with capsule cam 852, Pilcam 803, Marocam 315, and I will give you our data. The visibility of the papilla fateri in our series, 81.7%, you've seen it before. With the Enview systems, Pilchem and Myrochem only 9.6%. We have a complete examination, the entire small bowel in 97.4%, with the Enview systems in only 84%. That's because of the extreme long recording time of 20 hours. Detection rate in the CapsuleCam series 51%, with the Enview 44%. It's statistical high significant difference. A loss of data, CapsuleCam 3.1%. It's because when patient can't retrieve the capsule, we don't have any data. So if they miss the capsule, we have lost the data. But we have in the same period with the Enview systems, because of failures of the data recorder or the built-in SD card or with the sensor belt, a loss of data of 6%. A download time, it's the fastest download time of all those capsules with the Pilchem system, around 90 minutes. With the Pilgrim Crowns, it's higher because of a lot of data. The reading time, half than with the SP3 or the Myrochem, because of a special dual mode, so we can have a quicker look to the complete examination. And we have the same image quality for all the systems, and I will give you here a short example of those images. We have the SP3, it's the market leader with a really fantastic view to the mucosa. You can see every villi, but if you look on the CapsuleCam, we have the same details and we have the same image quality. So I think it's a big step up. So now at the end, I will show you our data of capsule endoscopy in our Crohn's disease patients. We have included 633 examinations between 2003 and 2018, 291 with CapsuleCam, 342 with Pilchem or Myrochem, whereas the most Crohn patients were examinations with the Pilchem. We have included patients with suspected Crohn's disease or known Crohn's disease with suspected small bowel lesions. We performed upper and lower GI endoscopy before the capsule endoscopy. We have no imaging mandatory. The exclusion criteria was pain as leading symptom, and that's the only reason where we say no capsule endoscopy if pain is the leading symptom. We have done 2 patency capsules long ago. I think it was 2004 or 2005, I can't remember. And we have a rate of cross-sectional imaging in our group in less than 15%. So we are working like the ESGE guidelines, no cross-sectional imaging or patency capsule mandatory. And what are our data, the results? We find significant lesions in 36%, which led to change in therapy. We have a retention in 5 patients, which means 0.79%. It's around the number for the retention rate in the group of the gastrointestinal bleeding. 3 are solved by enteroscopy, and only 2 patients needed surgery, means 0.32%. And in those patients, we have before a cross-sectional imaging, but they can't find a stenosis even after the retention. It was not seen on the CT or MRI scan. And if we go back, please remember 0.32. I want to go back to the symptomatic retention of the patency capsule. In this series, we have surgery in a bigger number in 0.79. So that's the reason we don't use patency capsules. And we have done a subgroup analysis for the used capsules. And here we can find with the Capsule Plus system significant findings in 43.9%, and in the end view group 31.3%. So overall, we have a statistical significant benefit for the Capsule Plus system. So for the future, I think we will need more studies with multi-camera capsules, and I'm thinking that the single-sided capsules will be running out over the next years. We will find more pathologies with multi-camera capsules. And at last slide, I will show you my working space. That's like capsule endoscopy fetishists are working. And so as a thank you for your attention.
Thank you very much, Professor Pachofszky. Is there any questions from the floor? Okay, so Dr. Ahmed Zaid will have a question.
Thank you, Dr. Thomas, for this very nice presentation about capsule endoscopy. We know that one of the limitations of capsule endoscopy is the use of NSAID. Can you differentiate between NSAID ulcer and Crohn's ulcer or IBD ulcer? The second question is, for how long should we stop NSAID before doing capsule endoscopy?
Two very good questions. Thank you. The first, no, we can't say this is an NSAID ulcer or a Crohn's disease. Yes, we know we need the medical history. We can only describe we have an F2 lesion, we have an ulcer, but it's the same. If you have a tuberculosis in the small bowel, it will look like this. If you have a morbus Bechet, it will look like this. You can also have those small F2 lesions if you have an infection or post-infection. So we only can say we have some lesions. Maybe we can say it's a typical feature where they are, but we can't say from the capsule endoscopy, this is a Crohn's disease. For the NSAIDs, yes, it would be best if you can stop it 4 weeks before.
Okay, thank you so much.
It's not every time possible, but 4 weeks would be the perfect time.